Hello, I'm Dr. Vanessa Salcedo, Director of Wellness and Health Promotion, and I want to welcome you to our Grand Round series. Today we have the pleasure of having Josephine Dolera, who's our Director of Rehabilitation Services. She'll be talking today about physical rehabilitations and their services.
Good afternoon, everyone. My name is Josephine Dolera, Director of Rehabilitation Services at Union Community Health Center. And we have here today our specialist. First is Dr. Tony Cheng, who's a certified hand therapist and certified lymphedema therapist. We have Dr. Anisha K here, who is certified vestibular therapist. We have Yaneth Serrano here, who is a pediatric therapist. Yaneth Serrano, who is also a pelvic floor rehab therapist. And we have Miroslava Montesdeoca, who is our senior occupational therapist and a certified lymphedema therapist. Last but not the least is Ms. Nishiyama, who is spearheading the wheelchair program. So today we're going to discuss about PT and OT in order to give you a better perspective of what we do. Some of you might already refer patients to PT and OT, but there's always a question. When can I refer patients PT? When can I refer patients to OT? There's always a question mark on that one. A lot of you guys know it's always PT, right? So, by definition, what is a physical therapist? According to APTA, physical therapist is a movement expert who improves quality of life through prescribed exercise, hands-on care, and patient education. Diagnose and treat individuals of all ages, and we do that at Union. From newborns to people at the end of life. So basically, we are the specialists in evaluating and treating individuals with treating disorders of the human body primarily by physical means. Also, we focus primarily on individuals with physical impairment related to musculoskeletal, cardiopulmonary, neuro, and lymphatic system. So when we think about PT, what do you have in mind? Gross motor movement. What is gross motor movement? It involves large muscles such as the trunk, core muscles, and the thigh. So you think about spine, that's what comes into your mind to physical therapist. So what's the definition of an occupational therapist? So occupational therapists are licensed health professionals who help people find ways to do daily activities or what they need to do. Sorry, again. Okay. So they're concerned with promoting health and well-being through occupation. But when you said occupation, what does it relate? Profession, job. But it also entails its everyday activities that let us live independently and give meaning to our lives. It helps enable person to participate in activities of everyday life. We might not think the importance of daily activities until we find them hard to do, especially our patient. So, finding ways how to do them, that's what OT concerned with. Those are the things that they specialize. So when we think about OT, it's completely opposite with PT, right? Fine motor movement. So what does it entail? Smaller muscles, which is our shoulder, the elbow, and the hand. So since we have definition of both PT and OT, so what's the difference between the two? So, it says that physical therapy will teach you how to walk. That's gross motor movement. And OT will help you get a date and enjoy the dance. Fine-tuning of the movement. PT's focus on body's physical function. OT's focus on applying the body function to daily activities. PT's focus on strengthening what muscles you still have. Meanwhile, OT's focus on practical usage of those muscles. So, however, both of this discipline maintain or restore health through physical examination, diagnosis, prognosis, patient education, patient intervention or physical intervention, disease prevention, and health promotion. So, why is it crucial for physical rehabilitation with our patients, especially our patients recovering from illnesses or any injuries? It is crucial because a patient's recovery, the one presented an impairment, functional limitation, disabilities, change in physical function. If you have a patient, a stroke patient, who used to ambulate for very independent activities of daily living, here we go. Sitting on the wheelchair. But doesn't mean that they're going to be sitting in the wheelchair for the rest of their life. Rehab comes into play. So, therapists also help encourage patients to make lifestyle changes by educating patients the importance of exercise, which help avoid any future injury and promote overall health and wellness. So, as I mentioned earlier, PT and OT has different specialties, and both disciplines kind of cross over. Both disciplines has orthopedic, a lymphedema program, and also pediatric. The only thing that differs is that physical therapy have a pelvic floor rehab, vestibular rehab, meanwhile OT has lymphedema wheelchair program and hand therapy. So each of these specialties can be discussed with our respected therapist. So I'm going to be talking mainly about orthopedic cases that we treat. As what I mentioned earlier, PT is involved in gross motor movement, so and OT, fine motor movement. So the common conditions we treat for ortho is, for physical therapy, are neck and low back pain, post-operative orthopedic procedures such as total knee replacement, total hip replacement, ACL repair, acute or chronic sports injury, arthritis, sprain, and strain. Meanwhile, for OT, as what I said, they engage upper extremity, pre- and post-operative procedures such as shoulder replacement, rotator cuff repair, or shoulder arthroscopy. Common shoulder injuries is impingement, tendinitis, tendinopathy, and instability. And a lot, cumulative trauma, which is a repetitive injury, and I think we have a lot of our employees who has that, such as the carpal tunnel syndrome, or nurses. Tennis elbow, golfer's elbow, trigger finger, also rheumatoid arthritis, OA. And we have a lot of patients with fractures, elbow, wrist, and hand finger fracture. And commonly treated for a hand therapy is post-flexor and extensor tendon repair. So I would say that union, in our cases, I would say majority of our cases, I would say 75% are orthopedic cases. So 25% is the remainder of our specialty. So, provided that's when unit comes into play, because a lot of you guys are not highly aware of what we have or any specialties that we have. Mostly you guys just think we do ortho, but we're beyond that. I'm proud to say that Union has several specialties in rehab, PT, and OT. So, also, we do handle cardiopulmonary and circulatory conditions. A lot of you guys who are COPD or emphysema, how are they going to come to you? By wheelchair, right? And most of the time, they're going to complain difficulty walking or shortness of breath or dyspnea upon exertion. Please refer them to us. That's when it could come into play. OT and PT is going to work on that. So, neuro cases as well, such as stroke, traumatic brain injury. The reason why I put TBI here, we're not really a TBI facility, so what we're handling is highly functioning TBI. Parkinson's disease, cerebral palsy, PNI, and multiple sclerosis. So, what I listed here is our common approach. It doesn't mean that all of our patients will get this prevention. So, just to name a few, manual physical therapy techniques such as myofascial release, joint mobilization if there's any joint limitation, so, and also cross-friction massage for any scarring. Our main focus also is exercise, which is strengthening, balance, and coordination training. Application of therapeutic modalities such as ultrasound, electrical stimulation, and iontophoresis. We use it mainly for our patient who is suffering pain. We apply it before and after, or even after exercise. Orthotic and prosthetic training. Even though we have a third party that we outsource as a prosthetist, but PT and OT still engage with the training. Biofeedback and bladder rate training for our pelvic rehab. Customized splinting for upper extremity. I'm really pleased to announce that we're one of the few who does customized splinting for the upper extremity. We don't do it for the lowers. Again, we use vendors for the lower extremity. Wheelchair mobility training, and Mr. Takako is going to dive in deeper later on. Self-care skills training, which is activities of daily living. Pain and scar management. A lot of our post-op patient suffers decreased scar mobility. So OT is focused on that one as well. Kinesio taping. A lot of you guys know about kinesio taping. You've seen them in the Olympics with those players, with the tapes and everything, right? Colorful tapes. So we do that too. That helps to relieve muscle pain, joint and ligament pain, and also enhance patients' recovery. We do fall prevention, injury prevention, patient and family education. So last but not the least, this is the newly acquired equipment that we have at 3rd Avenue. It's called Altergy. Altergy is an anti-gravity treadmill. It's just like a treadmill in steroids, actually. So it uses NASA technology. It helps or allow patients to walk or run or perform close kinetic chain exercises with reduction of impact on the joint without even impeding biomechanics, unlike the harness and the hydrotherapy. So I'm not sure, guys, I'm talking too fast, I'm sorry. So if I am, just raise your hand. So to summarize, PT and OT, the union is very unique. We kind of divide the body. Any shoulder, elbow, hand-related injury, we're going to refer them to our OT specialist. When it comes to cervical spine, thoracic spine, lower back pain, hip, ankle, and any toes injury, that would be our physical therapist. Even though sometimes we overlap with each other, patient referred to PT, usually PT, if they find it something which is related to fine motor movement or related to OT, we refer them back to our occupational therapist. Or even speech, we refer them. So that's where it comes into play. Union is very unique with that one. A lot of places, it's only PT, mainly PT. So here at Union, we have PT and OT, who kind of treat upper extremity, and PT lower extremity. So, guys, in terms of the question, I would really highly appreciate it if we could defer the question towards the end. That way we had enough time for the rest of our speakers. So, next speaker, I'm going to hand it to our Assistant OT Director, Dr. Tony Cheng. Again, as what I said, he's a certified hand therapist, one of the few in the Bronx, and a certified lymphedema therapist. Go ahead.
Thank you. Thank you, everyone. My name is Tony Cheng, Doctor of Occupational Therapy, specializing in hand therapy. Before I talk about hand, I always have my own definition of the difference between OT and PT. So many people like to ask. And I say the basic difference is the average salary of PT is slightly higher than OT by $3,000. That's kind of the joke. Okay, occupational therapy focus on helping patients master their activities of daily living. Physical therapies focus on helping patients recover range of motion. That's what we learn in school. I'll give you a real example. One time I received a referral. The doctor wanted the patient to have both OT and PT for the patient's frozen shoulder. So, how do we divide? In here, at Union Community, we're supposed to have either OT or PT to treat the patient. But the solution is, we go by the definition. Anything occupationally meaningful to the patient, for the patient, it belongs to occupational therapy. Physical therapy is anything physically meaningful. For the patient's physical independence, it should belong to OT. So, for the patient with frozen shoulder, the physical therapy will work on recover range of motion for the patient. And then for occupational therapist, the job will be to assist the patient to put on the shirt, to wash the back. That would be perfect. The vision of between OT and PT, if we both going to see the patient for the same diagnosis. But like Josephine said, the reality is totally different. At Union Community Health Center, from the shoulder to the hand, it belongs to OT. And the rest of the body, PT will take care of. Okay, so now, hand therapy, occupational therapy, specializing in hand therapy at Union Community Health Center is one of few facilities in the Bronx, and run by Hand Therapy Certification Commission certified hand therapist, which is me. Okay, so to become a certified hand therapist, you need to be OT or PT who has a minimum of 3 years of clinical experience, including 4,000 hours or more in the regular practice in hand therapy. So in addition, the certified hand therapist has successfully passed a comprehensive test of advanced clinical skills and theory in upper quadrant rehabilitation. And because the changes in this profession, every certified hand therapist is required to demonstrate a continued professional development and competency by certifying every 5 years. So every 5 years, we have to go back, be recertified. And common diagnosis treated by OT and hand therapy, which is kind of different from regular OT and PT. There will be certain cases the doctor only want a hand therapist to take care of. Because the art and the science involved with hand therapy, there are certain injuries, especially tendon repair. Flexor tendon repair, extensor repair. But mainly, the doctor will refer injuries and conditions of the hand and the upper extremity, which a lot of times will include shoulder, arm, elbow, forearm, and wrist. And especially after surgery, that's a lot of times when the doctor will want the hand therapist direct care. So, a doctor usually will prescribe, this is a good example, a doctor may prescribe hand therapy for a patient after hand surgery. Because if unprotected finger motion begins too soon, too early, the tendon repair is likely to fall apart. And which it happens once, one out of, they say, 250 cases, which is not very high. In here, 15 years of practice, this never occurred. Okay. Now, so why would a doctor, a patient choose outpatient occupational therapy, hand therapy at Union Community Health Center? So usually this is a question we ask the doctor, the patient. Do you have an occupation you want to resume? Is your injury prevent you from going back to work? Is the quality of life affected by your injuries? Does your daily activities become a burden to you after injury? Does your injury stop you from engaging in sports and leisure activities with your beloved friends, family members? If the answer is yes, Union Community Health Center Rehab Department is the answer for you. Okay, so the uniqueness of OT hand therapy at Union Community Health Center. Splinting fabrication for preventing or correction of injuries is a big portion of what we do at Union Community Health Center. Individualized exercise program to expedite progress. Activity of daily living, modification, counseling, and independent living training. Design and implementation of home exercise programs to increase motion, dexterity, and the strength. And of course, patient and family education. OTPT interventions. Splinting for the upper extremity. Modalities in rehab department, we use iontophoresis, TENS units, laser treatment for pain management. We also have specialized manual therapy, joint mobilization, and home exercise programs, and kinesiotaping that Josephine mentioned earlier. And what can we treat with kinesiotape? Musculoskeletal disorders, AC joint discomfort, disorder, injury, bicipital tendinitis, Achilles tendinitis, brachial plexus syndrome, carpal tunnel syndrome, elbow bursitis, headache, medial lateral epicondylitis, patella tendinitis, and the shin splints. So we use kinesiotape almost every day, a lot. Like most patients like it. Psychologically, it's beneficial. They like the actual care on their body. Okay, so this is the most special part of what we do at Union Community Health Center. Customize the splints for complex upper extremity disorders. The picture on the left is an airplane splint. It's a complex splint that holds the arm in abduction with the forearm at approximately 90 degrees of flexion. It took me like 4 hours to complete. So it's a special order. Usually that requires a lot of communication between the surgeon and rehab. And the picture on the left is extensor tendon repair. It's a dynamic splint, which is a splint with like a sling that allows some finger motion and may be used for injury like zone 2 and 3 extensor tendon repair. And the dynamic splint allows early movement and protect the healing tendon. So that's back to what we mentioned earlier, like certain diagnoses. Sometimes the surgeon, the hand surgeon, usually like a certified hand therapist to attend to the patient directly. And there's an example about why tendon injury is kind of difficult to be attend to some therapists. Because in school we don't receive actual training in hand therapy. And a good example, when I was studying for hand therapy, there's an example. Tendon injury was used to be called no man's land, which means like no man can do it right. And now, because of more advanced hand surgery and the hand therapy knowledge theories, is now called some man's land. Some men can do it right. And that's kind of to summarize the uniqueness of rehab department hand therapy at Union Community Health Center. And the next we have Yaneth to talk about pelvic floor. Thank you.
I'm Yaneth Serrano. I'm a therapist who works in pelvic floor rehab, male and female. So millions of women especially experience involuntary leak of urine called urinary incontinence. I'm going to change that because it's not only women, males too produce that, have that problem. So in the community, 10% or 35% of dwellers have that problem. In the nursing homes, residents, 50 or 60%. But the problem is that only 20 or 50% of people go and see the doctor because they are very afraid or they are embarrassed to talk about that problem. So the urinary incontinence can be slightly bothersome or totally disabilitating because the people, especially women, they feel very embarrassing to go out in the community and leaks of urine. So they don't like to go outside to have activities, or they don't have visit the friends or family. In many ways, the muscle dysfunction in the pelvic floor is the same that any single muscle, the legs, the arms, they are the same kind of fibers. So we have to take a simple view of that area so the patient don't feel embarrassed. That the muscles can be weak, in which case they manifest as incontinence or prolapse of the muscles and can be a state of tension or increase the tone and will manifest eventually in sexual and constipation problems. The therapist's role in that pelvic floor dysfunction is to perform a comprehensive history of the pelvic symptoms that the patient presents and help the patient to understand what caused that problems of the dysfunction of the pelvic on how the physical therapy is going to work, explaining the anatomy, how that works, that they can understand. We perform examinations of the muscle group of the pelvic. We see external and internal examination, all the muscles. We check the muscle strength, we check the quality of movement, we check the sensation, trigger points, pain, and these abilities on the contract and relax or bear down the muscles. We use biofeedback. We develop an individualized treatment plans according to each problem that the patient has. And we educate the patient in postural, because it's very important for the pelvic core, and we teach them how to retrain the bladder and especially continue with the special diet that avoid the irritants of the bladder. Okay, the pelvic floor muscles, how they work? They work like in a diamond shape. So it's the symphysis pubic and the ischial tuberosities, that is called the seat bones, and the coccyx, that is called the tailbone. So the pelvic floor muscles work like a hammer, that they contain the uterus, the bladder, and the colon. So they hold all the organs in place. They work as a constrictor function of the urethra, vaginal, and anal canal. And if they have important part on the sexual function, gaining and maintaining the penile erection. Okay, so the pelvic floor evaluation is we ask the patient to tell us when the problem starts, to tell us all the history. In case of women, we ask the pregnancy, how many kids they have, how was the delivery, what kind of delivery. We do palpation, external palpation and internal palpation to check the sensory and the strengthening. We use the biofeedback to check the resting tone and the quick contraction. We assess the muscle strength, extra and intravaginal. In the males, we check the anal canal. The pelvic symmetry is very important. If all the organs and all the muscles and all the bones are in place, so up sleep, down sleep, anterior, posterior rotation. The standard of treatment. We do manual therapy, we do therapeutic exercises, we assess the psychological impact and social impact of the patients. We use modalities like electrical stimulation, ultrasound, massage. We use dilators, we use the surface electromyogram, breathing exercise, relaxation techniques, patient education. Let's see what else I have here. See that that's it. Oh, I think that's it. Oh, sorry, no, I have a part. The common objective findings. We find short muscles, we find tight muscles, we have relaxing muscles. The way we check the tone, if it's a hyper or hypotone. We check the low back, because sometimes the low back pain impact a lot in the pelvic problems. We check the lower extremities. So in general, we search for the whole pelvic core and legs and back. We check the weak pelvic muscles, musculoskeletal dysfunction, more difficulty relaxing pelvic floor muscle, that is very common lately because it's a lot of stress, so the people tie the muscles and they don't do PE easily. So the common diagnosis that we see is chronic pelvic pain, tension, myalgia, dyspareunia, vaginismus, vulvodynia, interstitial cystitis, and general sexual problems in male and females. So that's it. So the next person is Takako. She's going to talk about wheelchairs. She's an occupational therapist.
My name is Takako Nishiyama. I'm an occupational therapist, and we're going to talk about wheelchair evaluation today. Let's see. Okay. Wheelchair evaluation is to give specialized wheelchair to patients with qualified diagnoses and conditions so that patients can improve their function and improve quality of life. So to qualify for specialized wheelchair, patient must have a long-term conditions or permanent conditions that is disabling to them, that they're not able to walk functionally. Usually the temporary conditions like fractures or debility from pneumonia or something like that, it is expected to improve, then that's something else. That would be a different type of simple wheelchair, but we specialize in more complex wheelchair that insurance requires a lot of justification to obtain. So let's see. So here we have standard manual wheelchair, which is a short-term use, and it has minimum to zero adjustability and not much positioning capabilities. Those are the ones that you see in front of in emergency rooms, and then those are the type of wheelchair that we don't really evaluate for. The complex manual wheelchair that you see on the other side, that's the type of wheelchair that we evaluate for, which has a lot of adjustability, provides positioning capabilities such as tilting space functions, adjustable headrest, leg rest, armrest, and lateral support for people who might not have a trunk stability. And also they provide pressure relieving management. And that can be manual wheelchair, and then also power wheelchair could be standard power wheelchair that is simple scooter type, or a simple power wheelchair with a joystick, and also has all the other positioning capabilities. That's a complex power wheelchair, same as the ones that I talked about in manual wheelchair. So let me talk about. So occupational therapy wheelchair evaluation includes assessment of medical conditions, medical history, diagnosis, the fall history, and then pressure ulcer history. We also talk about living situations, what kind of support the patients are getting. Do they have home health aid? Do they need family support? Or are they functioning by themselves? Also the environmental factors, like if they live in an apartment that requires going up and down the stairs, or do they have an elevator accessible to elevator, so that they'll be able to use a powered wheelchair from community to their home. We also do ADL status. We assess the mobility status. Sometimes we refer them to physical therapists to see their ambulatory status, to see how safe they are to ambulate on their own with certain devices. We also assess their range of motion throughout the body, muscle strength, sitting and standing balance, coordination, and posture in seated or standing position. So that would determine what kind of chair that we we want to prescribe to the patients. So we also work with assistive technology professionals. They are vendors, and we work with Miss Victoria Wells from National Seating and Mobility. That's our vendor, and we sit down and look at the patients together to determine what equipment patient might need, what positioning devices that they might need, and then also we also look at what equipment that patient will qualify, so the insurance will pay. Patient also has to go to face-to-face evaluation with a medical doctor. We have a in-house physiatrist, Dr. Akapedi, and then a lot of our patients goes to her, and then doctor also evaluate what type of wheelchair they might expect to get. So all three of us get together and complete the letter of medical necessity, and we submit it to the insurance. And then the insurance will take about 1 to 3 months, depending on what kind of insurance and what complex equipment that we have to justify to get. And then finally, the patient will receive a new wheelchair. And they'll come back in and do our OT will do the fitting and delivery process, and we'll do the trial and make sure the patient is able to use that chair effectively at home. So if you guys are medical doctors, please give us referrals for wheelchair evaluation. We'd like to have the referral to have diagnosis. We've been working with patients with diagnosis with like cerebral palsy, MS, muscular dystrophy, paraplegia, scoliosis, obesity, COPD, cardiac conditions, and respiratory conditions, and any combination of those diagnoses. So that's it for me. What's next? Yeah. Okay. So I'm introducing Miro. She's an occupational therapist who's going to talk about lymphedema therapy.
Yes, hello. My name is Miroslava, and I am one of the two lymphedema therapists in the Union Community Health Center Rehab Clinic. My colleague, co-worker is Linda Lang, and she's a physical therapist that provides lymphedema therapy as well. Okay, what is lymphedema? It's an excessive accumulation of high-protein fluid, lymph fluid, in interstitial spaces due to a disruption in the normal lymphatic transport. Over time, it can lead to fibrosis, hardening of the dermal tissue, chronic inflammatory reactions, and very poor healing of that extremity. The most common type that we see in the U.S. and that we see in our outpatient clinic is secondary acquired lymphedema, which is a result of maybe tumor, maybe trauma, chronic venous insufficiency, the treatment of medical conditions, most notably of the breast cancer, radiation therapies, and other treatments for other malignancies. There are about 4 stages of lymphedema. We generally want to see the patient in the first or second stage. These tend to be reversible. Once they get to the 3rd and 4th stage, it becomes kind of irreversible, and we can shrink the limb size, but it becomes a more tedious and difficult task, and more than likely they will, at this stage, they will not get return of the normal lymph size. These are the 4 stages. So in the first stage, you won't really see anything obvious, but the patient will already feel discomfort. In the second stage, you might already have some edema form. There'll be a little bit of accumulation of fluid, and you'll see some mild swelling compared to the unaffected limb. And then in the 3rd stage, you're going to start seeing a permanent swelling. There's going to be already some fibrotic changes. There's going to be scarring, a little bit of thickening of the interstitial tissues, and at that point, when you press into that extremity, there won't be pitting. Then the fourth stage is very advanced stage, elephantiasis. There's a large deformed limb, and there's a lot of thickening. But even at that stage, we can improve that lymph size and improve their function. General indications for treatment: if there's a loss of the functional use of the extremity due to the size, the girth measurement is obviously significant. If there's along 3 points, we usually measure 3 points, and if there's a significant girth size in those 3 points, wrist, elbow, upper arm, there's an indication for lymphedema therapy. If there's any scar tissue formation that limits their range of motion, or it disrupts their lymphatic drainage, and also for palliative care, for comfort and to prevent any further functional loss of the affected limb. And definitely for loss of range of motion that limits the patient's ability to even assume a radiation position that might be necessary if they're currently receiving radiation therapy. What are the treatment interventions? So what we provide is complete or complex decongestive therapy that includes manual lymph drainage techniques. We use various forms of low stretch bandaging for circumferential bandaging. Active range stretching, range of motion is very important for those extremities. Light strengthening exercises to get the muscles to pump some of that fluid. As skin care is important, we educate the patient on proper skin care and to prevent any breaking of the skin and any infection. Compression garments and how to train the patient on how to don and doff them. And lymphedema pumps are sometimes utilized, and we have a vendor that we work with as well that can facilitate this as needed. Patient and family education is very important for carryover, so that the patient continues to work towards the goal of reducing that lymph size, the limb size circumference, and home exercise program. And there are contraindications, so these patients should not be referred for a manual lymph drainage if maybe there's signs of cellulitis in the extremity, severe tenderness to touch, maybe systemic signs of fever, chills, myalgias. Definitely not if they have if there's a sign that they might have impaired arterial perfusion. If there might be an inkling of a chance they have DVT, deep vein thrombosis, we don't want to manipulate that extremity in any way if they might have that. If there's a potential for a malignant tumor that has not yet been treated, these are the early signs. We don't want to manipulate that extremity and push any of those malignant tumor cells to the healthy tissue. And usually if there is a malignant tumor, we can proceed with the manual lymph drainage after they've started maybe approximately 2 to 3 cycles of chemotherapy. If there's a history of CHF, if they have congestive heart failure, usually we definitely need clearance from the cardiologist before we begin manual lymph drainage. Renal failure, another contraindication. And patients with advanced malignant tumors, manual lymph drainage can be performed, but it would be palliative at this stage. And of course, we have to outweigh the risks, whether the benefits outweigh the risks of spreading the disease. So the best outcomes for lymphedema therapy are with early detection. There are red flags that we want to look at with the patient. Did they have pre-medical history of radiation, infection, trauma, surgeries, melanoma, breast, or any gynecological or abdominal surgeries? Had surgeries to the head, the neck, prostate, testicular, bladder, or colon cancer patients, because these patients could be at risk for developing secondary lymphedema. And if the patient reports symptoms such as, I feel like my extremity is swollen, or my body part feels heavy, full, clothing feel tight, any changes in the skin such as redness or thick or stiffness. They feel like they can't close their hand, make a fist, any tingling or aching, definitely loss of flexibility. And if they complain that as a result of the heaviness, the limb fatigues just during simple activities, right away they feel like they have to drop the arm. So basically our goal for OT and PT and lymphedema therapy is to restore function, increase functional mobility, improve their quality of life, reduce physical and psychological suffering that they do experience when they see that change in their body, and prevent the development of infection. And this can best be achieved if therapy for lymphedema can be initiated as early as possible before there's irreversible fibrosclerotic changes in the interstitium. And second, that would be it. The only last note that I wanted to mention is that if you refer a patient for lymphedema therapy, and if you could put please OT/PT, both services, it'd be to the patient's benefit rather than just putting physical therapy, lymphedema, or one or the other, because insurances sometimes would prefer to approve one over the other, or because the patient might have overutilized one service already. So if you could put OT/PT, that'd be great when you refer. Thank you. And I'll present you the next presenter, Anisha from Vestibular Rehab.
Hi, good afternoon. My name is Anisha Balanadu. I'm a certified vestibular therapist and impact trained concussion physical therapist at Union Community Health Center. So falls account for 3 million ER visits. More than 95% of hip fractures involve falls. 1/3 of community living older adults fall every year, and half of these are repeated fallers. So falls are the second leading cause of deaths in the age group of 65 to 85, and the first leading cause of death in the age group of 85 plus. So studies suggest in our patient population, if we start an exercise program in people 65 to 85, in that age group, at the age of 45, we can delay immobility to 90 and beyond. If our patients lead a sedentary lifestyle, immobility can encroach as early as the age of 60. A little anatomy. So our balance is controlled by our vision, our vestibular system, and our somatosensory system. As PTs, we train the vestibular ocular reflex, we increase proprioception, and we perform evaluations to distinguish between peripheral and central lesions. So these are some of the common conditions that we treat. In peripheral, we treat labyrinthitis, vestibular neuritis, PTBV, Meniere's disease, perilymphatic fistula, acoustic neuroma, and ototoxicity. Central, we do space-occupying lesions, lesions of the brainstem, thalamus, traumatic brain injuries, conditions like Arnold-Chiari malformation, multiple sclerosis, degenerative disorders, and encephalopathies, especially Wernicke's encephalopathy. Other conditions that we treat are migraines and motion sensitivity. Go back there. So, very often, physicians get a patient complaining of dizziness and loss of balance. So, in case of, say, neuritis, what do you prescribe? You prescribe a steroid, maybe meclizine, to mask the dizziness. But meclizine is a short-term solution. Chronic dizziness can change the neural pattern in our brain. And these long-term dizziness can cause perceived dizziness long after the condition actually resolves. So there is actually now an ICD-10 code for this called persistent postural perceptual dizziness. So this is something that is important because there is no real organic condition with these patients, but they do fall. So that's where vestibular rehab comes into play. So As physical therapists, we train the brain with vestibular ocular reflex exercises. In case of central lesions, we create alternative pathways through habituation. We strengthen the vestibular ocular reflex via exercise and increase their proprioception to compensate for loss. This holds true for conditions like tumors, strokes, and even concussions. We often teach our patients to fall, or rather land safely, and if they do fall, how to get up from the floor. As vestibular therapists, we have a nice team. It's me, Prunella, and Sherwin, right here at Union. We treat BPPV. That is a condition where the otoconia get dislodged and get into the semicircular canals. So you will often hear your patients say, "I'm dizzy when I lie down," or just when I look over my shoulder. YouTube videos to reposition these crystals are not the best because they often then get dislodged into another canal and your patient is even more sick. And meclizine is definitely not what helps these patients. At Union Community Center, as you can see in this picture, we use infrared glasses to study these eye movements. They give us a better understanding of where these crystals are located, and then we can use appropriate canalet repositioning techniques to fix them. And it's often just a one-time fix. So, at Union Community Center, we're passionate about vestibular rehab, and we have both practices at 3rd Avenue and 188th Street to serve our community better. So next we have, for pediatric rehabilitation, Olga Seraya.
Hi guys, I guess I'm the last, like the dessert. So I'm Olga Seraya. I'm physical therapist for 23 years. I do have 2 little twins at home, so I learn pediatrics every day from morning to night. Full-time job here and full-time job at home. So I'm going to give you a little touch-up on pediatrics today, and to make it easy, I'm going to divide it by 3 different stages. Let me see, I'm not very good with computers, but it's okay. So the first stage is from 0 to 3. This is stage of our little toddlers and babies. Unfortunately, they bring a lot of kids with prematurity. They have a lot of dysfunction. They have problem breathing, problem with the heart. But the major problem for physical therapy is the extension tone. When they have extension tone, it's really hard to achieve the milestone of development. So we need to do a lot of education for the parents, and also we have to do a lot of manual techniques, NDT techniques, and all others to achieve milestones of development, and so the child at 1 year old able to walk. The next one, I'm physical therapist, but I'm also going to talk a little bit about occupational therapy. And we have Ehlers palsy. It's not there, but it's also Klumpke's palsy. You probably don't know what it is, but this is compression of brachial plexus. It's one of the nerve root of C6 and C8 and T1. So what happened when the little baby or the toddler not able to use one of the hands? What happened? They're ignoring that part of the world and they cannot explore. So we're helping to get them there, so occupational therapists do. So, and the child later on able to, through the range of motion, through exercise and mostly play in that age, achieve specific milestones, so they're able to roll and so on. The next one is more neurological, is a good example is cerebral palsy. Unfortunately, we cannot heal them, but we can help them increase the range of motion, to be able to do some simple movements at that stage. The most common over my 23 years, it was torticollis. It's 2 kinds of torticollis exist. One of them is acquired. Usually it's the fault of the parents. They feed the child using only one breast in one position, or they put them to sleep in one position. So the child has the torticollis, and when the child has torticollis, in that situation, if it's, for example, torticollis looks like this, it's on the left side. So they forget about the left side totally, and they don't use their hands, they don't use the legs, they don't roll to the side, so they don't expose to the wall on that side. Another one, it could be the torticollis could be during the birth as a trauma one, and also the child could be burned with torticollis already. Some orthopedic diagnoses involve club feet. So mostly club feet we don't treat. We get them after the surgery, and we work appropriately with them depending if they're missing range of motion and strength. We work manually and teach the mothers and fathers and grandparents sometimes just to take care of it in proper way. We always give them home exercise program. Next slide. Okay, the next stage, number 2, I would say, is from 3 to 6 is our toddlers and preschoolers. So what the most common things? It's usually they like to climb over tables. They like to jump. They like to run. And of course, they fall, they fracture, they dislocate. In that situation, we need to stretch, we need to educate the parents how to do the home exercise program. With this kind of kids, we play a lot using some toys and mostly the ball. The ball, the kids love the ball, so it's a great tool for us. Another thing, the little kid always wants to be taller. They want to be like their parents. They want to see more, so they go on their toes. So the toe walkers, it's so common in our practice. So it's 2 reasons for that. The second reason is they just have very sensitive heels, and they don't like the touching the floors or the grass or something like that. So because of that, what we need to do in that situation, we do desensitization of the heels and stretching there. So usually very helpful in that situation. Like I talked before, the nearer cases is spinal bifida and CP, it's cerebral palsy. I will repeat myself, we cannot help them totally, but we can in that situation, in that group, increase their proximal stability, so they can be more independent, they can transfer themselves, they can also even themselves stretch, and also parents, they are helping a lot. The patient education in all the stages are the most important thing. Okay. The last stage is from 7 to 18. We mostly treating them like adults. We have attention deficit disorders. Occupational therapists usually take care of that. They are working on their, concentrating on the task, writing skills, drawing, and so on. Another thing is orthopedic disorders. A lot of hormonal changes happen in that stage. So a lot of girls coming to me and complaining of low back pain. So it's another very common issue. Another issue, the boys, especially the boys, girls too, they like to play sports. And some of the sports are very vigorous, and especially like American football. So they get injured. Dislocations, sprains, strains, fractures, anything, you name it, they get it. So they come with that complaint. Okay, so what do we do with that? What we will do with that, it's actually my last slide, but I'd like to speed up the process. So what do we do in situation like that? In situation like that, we do stretching, we do manual techniques. We can do modalities because the A is age appropriate, except ultrasound, because growth plate, yes, it's not formed yet, sorry. So this, because of that, we cannot do ultrasound. Everything else, electrosteam, neuroeducation, strengthening exercises, stretching, of course, child, or not child anymore, teenager, and also education of the parents will be done. Okay, of course, family support is important, and hopefully we have a good family who can support those teenagers. And in early stage, it's important to go through milestone of development, and we're using a lot of techniques like inhibitory and facilitating technique like NDT. So it could be tapping, brushing. We can use different kind of filaments. We do a lot of things. Vibration is also very helpful for ease of those, and a lot of positioning and mothers and fathers education. I guess I speed up the process, and thank you very much, and enjoy your lunch.
Thank you so much, and all these wonderful services that I didn't even know we had, all this full range, and so it's a unique opportunity to hear about it. It's a wonderful opportunity that we have for our patients. I know we are over time, but if anybody has any questions, feel free to ask any questions. Do you have any questions? Yes.
So for like a frozen shoulder, do you want us to do 2 leg referrals?
No.
In OT, or
Just OT.
Just OT.
Yeah, just occupational therapy.
Because Tony mentioned how
I know,
range
yeah.
of motion, you would take care of that anyway, even though it's a larger.
Yeah, OT. Yeah, OT
You
does.
keep it simple.
Mhm.
Okay.
So I have a quick question also for Olga. As a pediatrician, I never thought about referring for ADHD. I know we have a lot of
OT. We're referring for OT.
both
Yeah.
to OT.
Yeah, PT doesn't.
Oh, okay. So it's mostly for OT, and that's, you said, for the writing and
Correct,
just
yeah.
yeah.
Occupational
And
therapist
and what
and so on.
ages do you like to focus on?
I guess OT can answer that. What ages OT will say?
Preschool.
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 Yes.
Okay.
Mhm.
Yes. Great.
Mhm.
Thank you. Interesting.
Yes, that.
Basically for vestibular rehab, I think the urgent care, primary care people were referring to Leah. Would she also just do that referral, or that?
You could refer for audio and PT to Dr. Ann, because Leah does the DNG.
Okay,
She does the VNG, and if she does fine, so we kind of
Okay.
talk to each other
Sure.
a lot.
Okay.
But it would be nice if it could be sent to us too. So
Okay.
especially if you find that it's a PPPV,
Okay.
because it's a quick one-time thing.
Okay.
So the patient doesn't have to go through all the testing
Yeah.
and then come to us.
Yeah. Okay. Great.
Fantastic. And then another common one we get is migraines.
Yes.
Yeah. So is that something for vestibular also?
Yes, especially if they complain of motion sensitivity. Because there are changes in the brain neural pattern with migraine. And then every movement, like even me moving my hands in front of them, bothers them. So we do a lot of good work with migraine.
Fantastic. Well, thank you to everyone once again. We really appreciate everything we did for our patients. And until next month.
On behalf of the rehab team, we want to thank you for joining the Grand Rounds today. To those who are physically present and virtually joining, thank you. We're looking forward to working with you and your patient.